Statistical Modeling, Biostatistics, and Health Economics. Ma'am, we are privileged to have you with us today, and we warmly welcome you to begin your session. Over to you, ma'am.
Thank you, Dr. Nabarun. Can I share my slide?
Yes,
Thank you for
ma'am.
that kind introduction. And I am also happy to be with you and all the participants from Assam. Most of you are from Assam, right?
I'm a Northeast.
Oh, okay. Very good, very good. So that's going to be a very interesting, I'm sure it's going to be an interesting session hereafter also. So today I have been given the topic of talking about fundamentals of evidence synthesis, in which systematic review is the most talked about and most conducted method. So I'll just share my slides. Is my slide visible?
Yes, ma'am.
Okay. So today I'm going to talk about systematic review and meta-analysis. So we start with clinical decision making. We all know that clinicians have a lot of work to do, because every day they have to take decisions based on their experience and also the knowledge about the subject. And many of the times the clinicians have to rely on literature review to find out solutions for their clinical problems. They look for studies till that date on that particular topic. What are the results of those studies, and what treatment recommendations have been given in those studies, and how these treatment recommendations are useful for their patients in their setup. So the clinicians have to keep reviewing the literature for this purpose. It's not only based on external review, but also from clinical experience of the individual clinician. It also depends on the patient's preferences and values also. Many times certain treatments are given to patients not only based on treatment guidelines or external guidelines, but depends on the patient's preferences also. And then definitely the clinician's personal experience is very important, and the treatment guidelines that the clinician has to follow, and all other scientific studies. Together, all this information is useful for clinical decision making. So what happens is that when a clinician does all that in a very judicious manner, in an explicit manner, to get the best evidence for decision making, to care his individual patients, then he is doing evidence-based medicine. So what is evidence-based medicine? Evidence-based medicine is a conscientious, explicit and judicious use of current available evidence in making decisions about the care of individual patients. Now, primarily, the practice of evidence-based medicine requires the integration of two major domains. One is the individual's clinical expertise, and the second one is the best available external clinical evidence. Now, the best available external clinical evidence happens from systematic search of literature, which is what we are going to see in my forthcoming slides. But we should also remember that these two broad domains cannot exist without each other. Without the former, that is, without individual clinical expertise, if clinical decision making is only based on external clinical evidence, then definitely many a times it happens that the evidence available from other countries, from other regions, are inappropriate and inapplicable or non-applicable in a particular situation, and therefore it is necessary to, in that case, use individual clinical expertise. And on the other side, if only if the patient, if the doctor depends on his individual clinical expertise, then his treatment may many times be outdated, because these days technological innovations, interventions happen so fast that the clinician has to keep up to date with the available information. So both these domains are very necessary for the practice of evidence-based medicine. Now, talking about evidence synthesis, what is evidence synthesis? Because we are gradually coming to the topic of systematic reviews, where evidence synthesis is a process of bringing information from various resources, from various multiple studies and various disciplines, and combine this information in a meaningful manner to inform decision making. And it is very useful to identify gaps in the knowledge. It establishes an evidence-based platform for best practice guidelines, and it also helps in informing the policymakers and practitioners. So evidence synthesis is the best method of evidence-based medicine, and it also produces important documents, outputs like policy briefs, clinical practice guidelines, and definitely systematic reviews. Now, you must be all familiar with this image that you see on the screen. This image is also called the hierarchy of evidence, or it is also called the evidence pyramid. If you look at the evidence pyramid here, what happens is that when small studies are conducted, because initially when small studies are conducted, they are conducted on a non-representative sample, on a small sample, on experimental basis, which does not have enough strength of evidence. But as you go along in the research process, this basic research turns into animal research, and then the research is done on human beings, and then epidemiological studies like case control are all conducted to generate evidence. And every step of this process generates more and more and better quality of evidence, which culminates into the best form of evidence, and that is called randomized control trial. Randomized control trial is an experiment of interventions on individuals, on patients, on individuals, which generates the best possible evidence. And on top of the randomized control trial is a systematic review. So as you see in the graph or in the image, systematic reviews and meta-analysis occupies the topmost position in the hierarchy of evidence, because it adds strength to evidence generated from the lower studies, as well as it reduces the risk of bias. There is lesser and lesser bias as you move up the hierarchy of evidence, but the quality of evidence increases as you move up. So systematic reviews occupy the topmost position of the evidence pyramid. On the right hand side, you also see a magnifying glass, because now some of the new authors have do not want to see the evidence pyramid in the manner that we have been told earlier, but now they say that a systematic review acts like a magnifying glass, which is able to filter information from all types of studies, whether they are randomized control trials, from whether they are cohort studies, whether they are case control studies, or even case series, or even unpublished literature. So it is that tool that helps us in filtering the best information from all types of studies. So gradually people are now using this image to show the evidence pyramid as compared to the earlier image. Now, talking about, so what is a systematic review? Systematic review is a summary of research results. It is a summary of evidence available in the form of literature that uses explicit and reproducible methods to systematically search, critically appraise, and synthesize information on a specific problem, specific research question. It synthesizes the results in a manner that from primary studies in such a way by using such strategies that minimizes the bias and reduces the errors. So what is a systematic review? Is a tool. It is a scientific method. It's a very systematic approach of comprehensive literature review using explicit methods. There is an explicit approach, explicit methodology is already in place, and there are standards of critically appraising studies that go into a review, and then there are standards of reporting the results in a manner easily understandable for the research and the scientific community. So it's a pure scientific method of doing a review. So when we talk about systematic review, we also have to talk about the usual narrative review. What is a narrative traditional review? A narrative traditional review is something that an expert or a group of experts in a particular field write in a narrative manner, which is just summary of evidence on a particular topic. It could be a descriptive or a qualitative summary of evidence for a particular topic coming from various literature, and there is no explicit manner in which the literature is reviewed. There is no explicit manner in which the literature is identified, selected, or the data is that is extracted from this literature goes into the review. It's a pure informal and subjective manner in which information is collected from various literature and collected and summarized, and the evidence is summarized. Therefore, there is a lot of difference between the traditional literature review and the systematic review. What are the various differences? We'll see. We should know that a systematic review is always with a goal, literature review is just to be answered in a traditional a research question is framed using the PICO method. We'll understand what is PICO method, and a clear hypothesis. A traditional review can be written by a single author or maybe more than one author, but a systematic review cannot be written by single author. At least there should be 3 reviewers for a systematic review, 3 or more reviewers for a systematic review. For a systematic review, there is a peer review protocol or a plan in place, whereas in a traditional review, there is no protocol. The objectives are well stated in a systematic review, but in a traditional review, the objectives may not be that well stated. There is no inclusion exclusion criteria for a traditional review, whereas a systematic review has a set inclusion exclusion criteria, which is written up in the protocol in the initial stage itself. For a systematic review, there is a comprehensive search strategy in place, whereas there is no such search strategy for a traditional review. There are list of databases, list of gray literature, and list of other sources which need to be considered for a systematic review, whereas in a traditional review there is no exhaustive list of literature, and therefore there is a high chance of publication bias in a traditional review. The selection criteria is explicit and clear in a systematic review for studies, for the primary studies that go into the review, whereas a traditional review has no such selection criteria, and often it is subjective in nature, and therefore it is prone to selection. Systematic review are all standard and well known, and it is published. So there is a method for synthesizing the results of the primary studies in a systematic review, whereas in a traditional review there is no such method. It is just summarizing evidence gathered from individual studies, and the conclusions based on a systematic review are evidence based, whereas a traditional systematic review conclusions sometimes may not be evidence based, because it is more influenced by the their author's beliefs. There are more differences between a systematic review and traditional review. We need to understand this, because a systematic review, the critical appraisal, every study that goes into a systematic review has to be critically appraised using standard checklists, and it goes through a rigorous appraisal process, whereas a traditional review, no such thing happens. Extracting information is also clear and specific in a systematic review, whereas in a traditional review it is not explicit. It takes almost 8 to 12 months for a systematic review till its publication, or till it's ready for in 1 or 2 weeks, because you are not subjecting through a process of rigorous primaries for a systematic review. Is that good knowledge? That means we should have a subject expert as the primary, and the searches have to be done from relevant databases. If the subject expert, he can still write a narrative review. And as you all see here, the value for a systematic review is very high, because it provides high quality of evidence that supports evidence-based practice. It has a reporting standard guideline of reporting the results, and it can be periodically updated as more evidence comes in. Systematic review and traditional narrative reviews are different, and for an evidence-based interchangeably, we have heard people using systematic review and meta-analysis. So please remember that systematic review can happen without meta-analysis also. Meta-analysis is a method, it's a quantitative way of pooling results from individual studies. So there is a possibility that many a times when we do a systematic review, you do not have the conclusion can be used without a meta-analysis also. So meta-analysis is actually a subset of systematic review. If the quantitative information is available. Now, what are the key characteristics of a systematic review? We all have seen that it is done with a clearly stated set of objectives. There is an explicit reproducible methodology to do a systematic review. A systematic review has primary studies in the review, and all these primary studies have to meet an eligibility criteria, which is a primary set checked then assessed in a systematic review, and the risk of bias, the confidence level of the cumulative estimates, all this can be generated. And as I said, there is a way of presentation of the result, synthesizing of the result, and all the characteristics and findings of individual primary studies included in the review are also to be shown in the final report. Actually conduct a review by search from that comes as a part of the entire. Once you do a systematic review, it is using the standard. Yes. Hello. Is there some question? Yes. Yes. Tell me. Oh, my network is lost.
हेलो, मैं कॉल करता हूँ मैम को, ठीक है? हेलो, हाँ डॉक्टर विवेक. She will join soon. There is some network issue. मैम आ गए. हाँ.
Yeah. Am I audible now? Am I audible? Hello. Yeah. Yeah. I'll do that. Am I audible now? Okay. Okay. I'll put off my camera. So, which slide have you missed, Dr. Vivek? Did you miss any slide? Slides are not visible. Can I see? Can you see my screen? Can you see? You are loud and clear? Okay, so I was just saying these. So I'll continue. So the main characteristics of systematic reviews, as I said, it has clear set objectives and reproducible methodology to follow. Sizing.
मैम का कोई नेटवर्क इशू आ रहा है लग रहा है।
नेटवर्क ही नहीं चल रहा है। Am I very I'm sorry for this, but my network is creating problems. Am I audible now? But I don't feel no, I don't feel comfortable till I am moving the slides, you know. Let me try doing it again. Are my slides visible now? It's visible, no? Okay. So I'll go to the next slide. So what I am trying to say is that the systematic review process include three main steps. One is to plan the review, where the primary reviewer is the person who generates the topic for the systematic review. The topic is selected, and then the reviewers as a group try to conceptualize and create a protocol. Second step, reading of the studies is done, and then each primary study that goes into the review, it is critically appraised using a standard checklist, and then the data, if available in a quantitative manner, is abstracted and then synthesized, and the results are interpreted. We don't stop a systematic review by just conducting a review, but we also try to document the review. We write a review report, we publish the systematic review, and then this, before it is published, the systematic review has to be validated by an external person who's not part of the review process, so that it is validated externally, and then finally the review is published. So now can you see the screen properly? Hello, can you see the screen?
Yes, ma'am. Yes, ma'am.
Okay. So if you see the screen here, it is actually a chakra view. So I tell people that if you want to do a systematic review, you have to enter this chakra view like Abhimanyu. So what happens is you start with an idea, and then that idea a person has, a reviewer has, he has to then search the online databases and see whether a systematic review on that particular topic has been done before or not. And if there is no such review that has been published on the internet, then that person can take that topic for a systematic review. And when goes about doing the review, he has to also try to answer this question as to, is there a strong rationale for doing this review or not? If a new review is warranted or not, because it includes a lot of resources. You see, the library resources, the individual's time, efforts, everything is included in for doing a systematic review, and therefore, till it is warranted, one should not attempt to do a systematic review. The third thing is that he has to establish a team of reviewers. So usually what happens is that the subject expert is the primary reviewer, and he is also supported by a statistician who has to be there definitely in the team, and then a person who can help him in collecting the literature. Then the search strategy is defined by the team. The selection criteria are properly written up and documented. And also a data collection form is developed by the research team to collect data once the primary studies are included in the review. Then they write up a protocol and register the protocol as you can publish a systematic review protocol also as a published paper. You can do that, and there are, I'll tell you how to submit your review in a registry. And then the search strategies are run, and then data are collected, the references are collected, and duplicates are removed. Two reviewers screen the title and the abstract of the list of studies, and then finally the full text articles are collected, and then data is extracted from these full text articles, and then if there are quantitative data available, meta-analysis is conducted. And during the process of meta-analysis, various other things are also checked for publication bias, for reporting bias, for heterogeneity between the studies, and all these questions are answered during the process of meta-analysis. And finally, when everything is done, then the quality of evidence of the systematic review is checked using the grade software, and then it is ready for publication. So the entire process is a 24-step process in which the reviewer has to follow this process to finally submit the review. Okay, so let us look at each of these, some of these steps which are important. One is to frame the research question. When we frame a research question as a systematic review question, we have to remember that there are two questions that are are included in the research question. One is the background question, which is the core question on who, what, why, and where, which we usually talk about in epidemiology. And the second is the foreground question, which is a more structured and descriptive question that talks about the specific knowledge about the health problem. And we should remember that when a systematic review is done, a well-formulated research question is the primary and the foremost step which is needed, that starts that helps you in the entire search process. It provides a focused search, and it guides in the selection of literature sources. Now, a well-formulated research question is in the in the format that is usually called as the PICO. What is the PICO here? PICO is the population, which primarily relates to the characteristics of the type of patient or the population that the research question or the health condition refers to. And the intervention is a type of intervention. It could be a medical intervention, it could be a diagnostic test, it could be therapy, it could be a procedure, it could be a management strategy, it could be a diet therapy. Any intervention that is done by the researcher on an individual patient is called intervention. And it could also be an exposure. Say, for example, when we are to systematically review observational study, the E component in the and the level of intervention or the dosage or the frequency or the duration of the treatment, all this becomes the exposure. And then the comparator third domain or non-intervention group, or the alternative treatment group or the control group in a trial or a study. And outcomes are the clinical outcomes of the intervention. It could be response to treatment, it could be improvement in the symptoms, it could be the improvement in quality of life, or it could be any kind of benefit that the patient gets from the intervention. Now, the PICO component or the PICO framework is actually falls in two broad domains, and that defines the kind of study that or the design of the study that we are looking for, and the methodology. So the first is the domain, where the domain could be a therapeutic domain, it could be a prognostic domain, it could be a diagnosis, or it could be a prevention domain. And the methodology could be the different study designs that one adopts for conducting primary research, like the cohort studies, the randomized control trials, the case control studies, or it could be just observational studies. So these two domains are the ones in which the PICO has to be clearly defined. Now, so if we look at it in a more detailed manner, we see that the PICO process for these different domains can be clearly answered. Say, for example, if we are looking at the therapeutic domain, then the patient's disease or health condition becomes the P component. The intervention or the therapeutic measure, whether it is a surgical measure or a medical intervention, could be the I component. The comparator could be a standard of care, or it could be another intervention or a placebo. And the outcome measures could be anything, any clinical outcome of interest, like mortality rate, or reduction in pain, reduction in any clinical problem. When we are talking about the prevention kind of studies, then the patient at risk for a set of risk factors could be the patient P component. The preventive measure or a vaccine, for example, because vaccines used for prevention could be an intervention, and there can be a comparator where you have no vaccine group as that comparator, and then the outcome measures. When we are talking about the diagnosis kind of studies, then the target health condition becomes the patient population or the P component. The diagnostic test or the index test that we are interested to test against a gold standard could be the intervention, and the comparator would be the gold standard. And then the outcome measures in such cases would be the sensitivity, specificity, the positive predictive value, and all that. Similarly, we can talk about the PICO process for other kinds of disease studies also, whether it is a prognostic study or a cohort study, where the primary patients who have the prognostic factor, who are followed up over a period of time, could be the patient population. Then, or the P component, the intervention could be just the time for an event to occur, that is the intervention, and then the outcome measures. So these are the various PICO processes for every kind of study that we can think of. But remember that to frame a research question, this process has to be followed. Once the PICO has been followed, then the research strategy has to be written according to the various components of the research question. So if you have a PICO, then against each component, we have to write the search terms, and then the search strategy is created. How do we do that? We'll see in our further slides. And remember that when we are talking about creating search strategy, we cannot search with only a single term. We have to use multiple terms, multiple alternative terms that mean the same thing for a particular component, and then only the entire search strategy can be created. I will show you an example on what I am saying here. But remember that we should have many terms for each component, and each of these terms are then combined using Boolean operators. So what do you mean by Boolean operators? In elementary mathematics, we have learnt about three major Boolean operators. One is a OR, which means A or B means either A or B or both. Similarly, A and B means A and B. That is the intersection term. So all this concept is also used for creating search terms and search strategies, and that is how you create a search strategy. Then once the search strategy is created, you write out the search strategy, you give details of the inclusion exclusion criteria, what type of studies are we interested, are we looking at randomized control trials, if randomized control trials, whether we are looking for specific health condition people or specific age group, or are we only looking at pediatric age group, or are we focusing on geriatric population. So all that will come in the inclusion exclusion criteria. And then we have to also limit our search. We cannot be searching articles for an indefinite period of time, because as we all know that in medicine, the strategies keep changing, new interventions keep coming in. So we, in order to keep the variation very little, we'll try to see, and our focus on certain interventions only, then we'll have to limit our search on the time limit. Say we will be searching only from year 2000 onwards, so that during after 2000, you would have, as a subject expert, you know that much would not have happened in the treatment strategy. And then the language limitations. In the language, you are only looking for English language articles, the year of publication, and the as I said, age group, if are we looking at any specific age group. Then are we looking for all types of studies or study designs, or are we focusing only on randomized control trials? We need to write that also in your protocol. And then all the databases that you need to be searched should be clearly written. Here are some examples of various types of questions that can be asked. For example, if it is a therapeutic question, in a 7-year-old patient with cystic fibrosis, can the use of respiratory physiotherapy for draining bronchial secretions compared to non-intervention reduce the rate of respiratory infections? So this is a very clear framed research question where the PICO component is clearly visible. As you see here, the patients with a 7-year-old patients with cystic fibrosis, that is the P component, and draining of bronchial secretions is the I component, and the C component is the non-intervention, and the outcome here is the rate of respiratory infections. If you see the second example on etiology or risk factor, the question is, in young female amateur basketball players, can supervised neuromuscular warm-up compared to usual warm-up reduce the risk of muscle lesions? So we're talking about female amateur basketball players, that becomes your P. Supervised neuromuscular warm-up becomes the I component. The C component is the warm-up, usual warm-up or the usual care, and outcome is muscle lesions. So this way you can define your research question in a manner that fits best into the PICO framework, and that is how it should be, because that helps you in then searching the articles of relevance based on these components. So these are some of the examples. And then also remember that when we look at studies and we try to create questions for our review, if it is a prevention or intervention, it is an intervention or therapeutic review, then the broad question or the research question could be framed in this manner. In population, what is the effect of an intervention on outcomes compared with a comparator? within a time framework. So if you frame your question in this manner, then it becomes a full-fledged research question with all the PICO components in place. Similarly, if it is an etiology question, then this type of question could be written: are patients or population who have an intervention at increased or decreased risk compared with a comparator with or without over a time period. So this is another way you can write up your research question. Similarly, you can write up a diagnostic question like this, where a index test is compared with a standard diagnostic test. So this is some of the examples. So once you have created a search strategy, we have to begin writing up a clear-cut protocol. A protocol is a research protocol where you have the background, the objectives, the hypothesis, all the methodology, which includes the creating of the search strategy, identifying the data sources, selection of the studies, evaluating the studies, critically appraising the studies, then how are the studies included, the PRISMA, which we are going to talk about in my next slide, and then the entire methodology of collecting the information from the individual studies, and then the risk of bias that is to be included. All that has to be added in the methodology, and we have to write it up in the form of a protocol. Now, why a protocol is needed? Because a protocol is needed because it is an explicit document that helps you in planning your review before you actually start the review, and it also helps us to keep going back to the protocol whenever we are at loss. You see, when we are doing a review, if you have a written up protocol with the methodology in place, then you can follow that protocol, and then you can look at your review methods and test the validity of the methods using this protocol. And most important is it reduces duplication of efforts, because if the protocol is written up and it is registered in a proper registry, then other reviewers will not duplicate the same method and duplicate the same review. They can do a different question. So it helps in reducing duplicacy and waste of resources. So how do we register your protocol? There are various ways of registering your protocol. The primary one and the most common one in which people register their protocol is the Prospero. So Prospero is something is a registry where you can register your protocol, and it is free. It is free, and it accepts all kinds of systematic reviews. Okay, so this is one way you can register your protocol. It helps in reducing duplicacy. Definitely, it reduces duplicacy. It promotes transparency, and it enhances your scientific vigor, because other researchers can also see the registered protocol, and then they can, if there are concerns on the criteria adopted or the methods adopted by the primary reviewer, they can contact the reviewer also. The contact details are also there. Not only that, some of the funding agencies have made it mandatory that when you publish your systematic review protocol, it has to be registered in Prospero. Some of the journals have endorsed Prospero registration because it gives you a registration number, and this also helps in commissioning or getting grants for your protocol or for a review, because some of the funding organizations also endorse the registration of your protocol. Therefore, registering your protocol is very important before you actually conduct the review. The other registry is the research registry. The research registry also takes protocols, but it is a priced registry. It takes about £99 for a systematic review, and it can register your protocol. If the systematic review that you are conducting is a funded review, then probably you can register in this registry also. The other registry is again is a priced registry. It takes about 21 US dollars for first time registration, and later on for every update it takes about $9. And this is the in classy registry where you can register your protocol. One good thing about this registry is that it provides you a DOI also. So therefore you can use this protocol and add this in your CV as a publication. Am I audible, Dr. Vivek?
Yes, ma'am. You are very much audible.
Okay.
Please.
So the other registry is the Open Science Framework. Many people I have heard that they have started Prospero because of overwhelming response from the researchers. Prospero nowadays has started rejecting some of the systematic review protocols. So the researchers are now trying to submit their research protocol or systematic review protocol in Open Science Framework, which is a free registry, accepts all types of designs, and it also provides you a DOI which you can use for as a publication. Another one is the protocols.io. That is another registry which is available free and provides you a DOI and takes your systematic review registration. So we have all this. I have repeated this. So what happens is that once you register your protocol, remember that in Prospero and in some of these registries, when you register your protocol, you also have to give one primary search strategy to them as a supplementary. So it should not be as if you have just registered a protocol and you have not even tried to do a search strategy. You have to create a search strategy in PubMed and then get the results of that search strategy, and then you attach it as a supplementary appendix for your protocol, and then your protocol gets accepted quickly as a manuscript in the journal. So the aim of the research strategy is to generate a comprehensive list of primary studies, and the validity of the review is directly related to the thoroughness of the search. As you keep searching, you keep on improving upon your search, and that generates more and more primary studies which you can go through and review, and they can be included in your review. And your as you all know, a systematic review has to be as comprehensive as possible, and therefore a comprehensive search strategy has to be adopted. Where there are various mechanisms of systematically searching primary studies. You can use electronic data sources like the PubMed, the Medline, and all the print data sources like the journals, textbooks, and hand searching. And also in systematic reviews, when we are using gray literature, there are databases where gray literature are published through. There are conference proceedings available which can be utilized for systematically searching the studies. When we are looking at electronic databases, there are, depending on the research question, their electronic databases are searched. For healthcare interventions, primarily the Medline, the Embase, the PubMed, and if it's Cochrane review, then Cochrane Central Register is searched. If it's a psychology systematic review, then PsycInfys data source which can be searched. Similarly, nursing professionals, when they are doing a systematic review, then Sinahal is the most common database that they search. Social sciences people, when they do a systematic review, then CSA, sociological abstracts, and Asia are the primary databases. And then there are other specific databases also, like age line, child data. Some of the BMJ services also provide you the databases for searching primary studies. When you searching internet sources, then AI driven search engines are available, like the semantic scholar, the Google scholar, the med archive or simple archive. All these are search engines which can help you in selecting studies for your review. And then thesis can be also searched, because gray literature comes in the form of thesis, and thesis can be searched from other universities also, using their websites. Then for published literature, Cochrane Library is definitely there for interventional and diagnostic reviews. For Cochrane protocols, Cochrane registries are there. For Medlines are there, and Embase is there for pharmacological and healthcare interventions. Web of Science is available for conference abstracts, for citations, for social sciences. Campbell systematic reviews are primarily used by researchers to search articles on social sciences. Then Scopus is another database which provides you conference abstracts, citation searchings, and other web pages. Then clinical trials registry, the CTRI of India. If you're looking for trials in India, then CTRI provides you the clinical trials, a registry of clinical trials. And for global clinical trials, clinicaltrials.gov can be searched. Then INDMED is there for indexing Indian medical journals, because sometimes Indian medical journals are not cited in PubMed, so we'll have to look for them separately. Then, as I said, sources of gray literature. Google Scholar sometimes has gray literature. Open Gray is there for gray literature in Europe. SSRN.com is it provides you a preprints of articles that go before the article is actually published. Then ProQuest and Shodh Ganga is available for thesis of from Indian universities. So once you have selected all these databases and you have the primary data in place, you have to, no sorry when you have all the data bases, then creating a search strategy is important. I think we have already talked about it, but here is an example where we'll learn how to create a search strategy using the PICO component. So suppose there is a question on effectiveness and safety of drug A compared to drug B. I'm not naming these drugs for ovulation induction in women with unexplained infertility. We are doing a systematic review to compare drug A and drug B. So the population would be, women with unexplained infertility. So you have to write women, you have to add women also, unexplained infertility. Some authors just write infertility due to some unknown cause, unspecified infertility, unknown infertility, so there are various terms that could be possibly used by various authors who published articles on infertility, and we have to take account of all these terms and combine them using the OR Boolean algebra. So you list all the concepts or alternate terms for the P component, and then combine it using the OR algebra, and there you get about 92,944 articles. The intervention is drug A. It could be any drug, or some common other terms for the drug A was aromatase inhibitor or aromatase or inhibitor. So you have to combine all these together separately also, and combined term also, and that led to about 17,23,605 articles. Then the comparator was the drug B. Drug B could be drug B, or it was also called metformin. It was also called gonadotropin. It was also called some other drug. So all the names of the comparator drug has to be written up and combined using the OR term. And that led to about 2,96,348 searches. Okay, so that many articles PubMed gave. And then the outcomes were the ovulation rate, the clinical pregnancy rate, the live birth rate, the all those outcomes that the question has. So put all those outcomes together, join them using the OR term, and that led to about 29 lakh 3,585 articles. So see, there are, for each component of the research question, you do a search and document this search. Then what do we do? Once you have definitely you cannot look at 29 lakh articles. So what we do is that also the study design. Since we are looking only for randomized control trials, but different authors publish their articles with different names. Say it could be a double blind trial or a single blind trial or a multicentric trial. So all those potential study designs for randomized control trials have to be identified. They have to be combined using the OR term, and that led to 33 lakhs articles. Then what do we do? Once you have the PICO component here, then the sixth search, as you see here, is you combine P and I first. When you combine P and I, then it leads to only 3,582 articles. Then you combine the C and O component. When you combine the C and O component, it led to about 83,000 articles. Then combine the sixth and the seventh. When you combine the sixth and the seventh, it reduces further to only 1,135 articles. And when you combine all this with the study design, it led to only 524 articles. So now the reviewers have to review only 524 articles to get the full text of some of these articles. Out of these also, some of them may not be eligible for your review and they may have to be dropped. So remember that when you do a search strategy, list all the databases, list all the dates of the last search. Everything should be properly documented. The language, the publication status, all the gray literature sources, everything should be clearly documented. Once all these titles of the articles are drawn from the literature, then the next step is to be done by two independent authors. The two authors independently screen the title and the abstract and see whether it meets the inclusion-exclusion criteria or not. If it meets the inclusion criteria as per the protocol, they are included in the review and they move on to the next stage. But if they do not meet the inclusion-exclusion criteria, then they are not included in the systematic review. But if there are certain articles which are not, the reviewers are not very clear whether it needs to be included or not, then they go to the third reviewer for adjudication. That is how the third reviewer is very important in a systematic review. The primary reviewer, the second reviewer, and the third reviewer. Then once the title and the abstract screening is done, then the full text screening is done. So some of these articles that were there in the abstract form may not be available in the full text form. So you will have to contact the original authors of those papers and get the full text if possible. You write to other libraries and try to get that full text article. You do everything to get that article, but if at all you are unable to get those articles, unfortunately, then those articles have to be dropped from the review. So remember that as we have been talking about systematic review, that it is a very scientific process in which everything is laid out. Every methodology is clearly laid out. So here also, when we do a systematic review, remember that you should be following a reporting guideline of systematic review, which is called the PRISMA guideline. This is the preferred reporting items for systematic reviews and meta-analysis. This is a PRISMA guideline which is available. The link is given here, and that guideline is a 2020 update of the PRISMA guideline that helps you in writing up your protocol and writing up in your review finally in a very systematic manner. So how does the PRISMA guideline work? It is a 27 item checklist which helps you in reporting the. It's please remember, it's not a conducting guideline, but it is a reporting guideline that helps you in reporting your systematic review to the scientific audience. It has 8 separate sections, which includes the title, the abstract, the introduction, the methods, results, discussion, and all other information. And it has to be reported in a systematic review in the form of a PRISMA flow diagram, where all the steps that you have adopted, right from identification of the studies, how many databases were searched, how many records were searched, how many were removed, why they were removed, how many were duplicates, reasons for removing, everything has to be recorded in the PRISMA flow diagram. And that helps you, that is the primary what you call diagram that helps a reviewer to look at your systematic review and see whether is any discrepancy or any any methodology that is inappropriate has been used in the review method or not. Well, let us look at each one of these. If the systematic review has to be always published, reported as a systematic review. I mean to say that when a systematic review is published, then it has to be titled as a systematic review. So whenever you see articles, you see here that most of the published literature goes as a systematic review in the title. Then the second one is the abstract. For writing up the abstract, there is a PRISMA statement only for writing up the abstract, which needs to be followed. It includes the title, the background, the methods, the results, the discussion, and all these steps have to be followed to write the abstract. Then the introduction should have a rationale and explicitly state the objectives of the review question. As you see in this example on cost of lung cancer, a systematic review, the introduction has talked about the lung cancer as a global problem. Then coming down to the end of the introduction, you have the rationale for why you want to do this systematic review. Then the methods should include the inclusion-exclusion criteria, the databases, the registers, the website, all those reference lists, the date of search, and full search strategies has to be followed. Then the method section should have the eligibility criteria, the data collection methods, all the definitions of the outcomes, the other variables included, and the risk of bias methods should be reported, and the definition of the effect measure that is used for defining the outcome should be clearly written. The method should also include the various approaches for synthesizing the results. Has this systematic review done a meta-analysis also, or is it just a descriptive synthesis? What are the inclusion-exclusion criteria for selection of the studies, the confidence intervals, the grading of for certainty of evidence, methods used, the various display methods, the tables, the graphs, the statistical methods, all this should be included. Then the results section should have the description of the results, the number of studies that have been included, all the citations of those, the description of those, and the studies that have been excluded and why they were excluded. Reasons for exclusion should be written. The risk of bias should be presented, and all the summary statistics in the form of 2x2 tables, and the patient study characteristics should be presented in the results. So all this is included in the result. So the PRISMA statement of 27 items checklist helps you in framing your review in a manner which is easily publishable and presentable. Okay, so all this is given in the PRISMA statement. So once you get the full text article, the next step is to critically appraise individual articles. The critical appraisal process has to be followed, and it is a rigorous process in which each article has to be read many times to understand what kind of studies have been followed, whether the results are results have been reported properly or not, what are the benefits and strengths of this research, what is the process, the methodology followed, are they reliable or not, what are the results, how to make decisions out of these results. Everything is the answer to these questions can be obtained only when you critically appraise the articles individually. So, and each reviewer has to independently critically appraise these articles. So, as I said, it looks for validity, whether the conclusions have been followed using a different specific methodology. Has he made reasonable assumptions or not? Have the sample size been properly calculated? Has it been reported properly? And what is the reliability of these findings? Is the effect significantly large? Has confidence levels been given? And is it useful, or can it be generalized for my settings? Is something that you need to assess using the quality assessment criteria. And checklists are available for quality assessment criteria. Various checklists are available, and every checklist is for a specific type of study. So if you are interested to review randomized control trials, there are checklists for randomized control trials. If cohort studies are to be reviewed, there are cohort study checklist. If diagnostic studies are to be reviewed, diagnostic checklist is there. For case control studies, there are checklists. So for every single study design, checklists are available by different groups of people. This is the CASP checklist, and the website is here. Then critical appraisal, the JBI critical appraisal tools are available for almost all types of studies. You just have to use these tools. Keep that a single or two-page tool with you for every study. Try to answer the questions given in the tools, and that helps you in critically appraising the study. It gives it helps you in a systematic way of reading the article. So all types of studies can be reviewed using the JBI critical appraisal tool, and some of the BMJ best practice guidelines are available for reviewing articles, and one can go through that also. And then Center for Evidence-Based Medicine also has its own critical appraisal tools. So one can use any of these tools to review the articles. So that's the main thing that we do in a systematic review. So what happens in a meta-analysis? As I have been saying, that meta-analysis needs quantitative data because it is a statistical method of collecting information in a quantitative manner from individual studies and integrating the findings from these studies using statistical methods. It's a quantitative method. It helps in generating a pooled estimate, which is a weighted average of all studies that are included in the meta-analysis. By combining the results of several studies, several small studies, we are increasing the statistical power and enhancing the generalizability of the results. Though it increases generalizability also. So remember that you cannot do just a meta-analysis. You have to do a systematic review, and in the process of doing a systematic review, you extract data from the individual studies, and then you combine the data using statistical methods, and that is what is meta-analysis. So when you extract data from individual studies along with the name of the author, the title of the study, you have to also extract the population that on which it was collected, the sample size, sample not the sample size but the population examined. If it is an interventional study, then the population who has been examined and the number who have the outcome of interest, all that information has to be extracted from each study. So we create a database in the form of an Excel sheet in which each row is the study, and then we have columns for all these extract data that needs to be extracted from individual studies. So the data should be so extracted that there is no need to go back to the individual studies at all. Once the data is extracted in the data extraction form, it gives you a summary of the individual studies, whether it is an RCT, how many individuals were there in the intervention, how many individuals were there in the control arm, how many got the outcome, how many did not get the outcome, what is the odds ratio, what is the risk ratio. All that information can be extracted from the individual studies. Then once you have the data extracted from the individual studies, you cannot use the data straight. It has to be in the form of some outcome measure which is of clinical relevance. So the outcome measure could be a proportion, it could be a event rate. So when we are talking about event rate, we remember that we'll have to look for event rate in the experimental group also, the event rate in the control group also. But sometimes the proportions are not available. There are measured outcomes like the blood pressure or maybe the glucose. In such cases, the mean of the outcome and its standard deviation is extracted from individual studies, and sometimes correlation for social sciences, correlation is extracted from individual studies. Sometimes we also look for response ratios in the form of ratio of the mean in the experimental group and mean in the control group. So once these data in this form is extracted from the individual studies, to make it compatible or make it available for combining the results from individual studies to integrate the outcomes, we'll have to convert that into a standardized effect measure. So the standardized effect measure for measurements, I mean the continuous outcomes, is the standardized mean difference, that is also called SMD, which is the mean in the experimental group minus mean in the control group divided by the pooled standard deviation. So if we are all statisticians, I think we understand this very clearly. And for small samples, we understand that this standardized mean difference becomes a biased estimate, and it provides an overestimate of the population difference, and therefore we'll have to do a correction factor, and that correction factor is given in the screen here, which is multiplied with D, so that we get a corrected standardized mean difference. That is what is used to combine the results. And we all know that for binary effect measures, it's kind of a 2x2 table, where the event rates in the experimental group and the event rates in the control groups can be defined using the cells of the 2x2 table. And we can also calculate the odds ratio, the risk ratio, the absolute risk difference, the proportion or the prevalence or the relative risk reduction, RRR. All this can be calculated using the binary effect measure that is obtained from the primary studies. So tomorrow when you are doing the hands-on on Stata, you will know how to generate these binary effect measures, which can then be used for combining the results. So these are all standard methods, definitions for OR and RR and their standard errors, and we'll use all this information to calculate the combined effect estimate. One more important factor that we need to see when we are analyzing the data from primary studies is to choose the model. So there are many other models. The fixed effect model, the random effect model are the ones which are the most common, but we have a mixed effect model also these days. And there are many other complicated models also. So the choice of the model depends on the question that you need to answer. Is your question like, did the treatment produce any benefit on an average in the studies that you have right now? That what you mean to see is that these are the only studies available. These studies are identical in terms of the patient population, the methods used, the measurements, etc. And whatever differences are there in the outcome measure is only due to the within study variation. So if that kind of a question is what you need to answer, then we adopt the fixed effect model. But let us always remember that when we are combining results from many studies, then it cannot be following a fixed effect model, because the studies come from different regions, different parts of the world, done by different investigators. So it cannot follow a fixed effect model at all. So then we come to the most more common method, that is the random effect model, which accounts for the heterogeneity seen. We know that there could be heterogeneity between the studies, and that heterogeneity is accounted for in the random effect model, where the question that we are answering is now, will the treatment produce benefit on an average, irrespective of whether they are homogeneous or heterogeneous. So if they are homogeneous, if the studies are homogeneous, if you use a random effect model, the results will be similar to a fixed effect model, because there is no heterogeneity. But if there is heterogeneity between the studies, then that heterogeneity is quantified in a random effect model by using the term, using the Q term. We'll see what is a Q term here. So before that, statistically, the fixed effect model and the random effect model looks like this. We are actually doing a weighted average here. See, so this is a weighted average where the weights are the inverse of the variances from individual studies, and yi is the effect estimate. Effect estimate could be odds ratio, risk difference, whatever. Okay, but whereas in the random effect model, we are the weights are not only the inverse of the variance of the individual studies, but also variance between the studies. So the between study variance is also accounted for in this kind of a model, and then that then calculates the weighted average. That the formula for all this is available, and when you do a data, you need not try to look for these formulas, but this is the basis for calculation of the random effects and the fixed effect model. What are the differences between the two? Fixed effect assumes that the effect size is the same in all the studies, whereas a random effect assumes that the effect sizes are different, which is true, which is more realistic. The purpose of a meta-analysis is to estimate the common effect for a fixed effect, whereas the purpose of a meta-analysis is to estimate an average of various effects. The weights for a fixed effect is the inverse of the variance of individual studies, whereas the weights of for a random effect model is the inverse of the variance, the sum of the inverse of the variance of individual studies and the between study variance also. So that's what it is. And in a fixed effect model, a smaller study gets a very little weight, whereas in a random effect model, all the weights are balanced. So these are some of the advantages of doing a random effect model. And given a choice, I would suggest that you always attempt a random effect model, which is more realistic. And as I said before, that if the studies are all coming from the same place, using the same methodology and same kind of patients, definitely they will be homogeneous. And if they are homogeneous, then the between study variance will be tending to zero, and the results of the random effect analysis will be similar to the fixed effect analysis. So when we are addressing studies from different places, there is bound to be heterogeneity. Heterogeneity could be in study designs, in the inclusion exclusion criteria, in the treatment regimen, in the duration of the treatment. It could be the quality of the studies, the whether randomization has been done or not, the biases involved in the studies. It could be due to various other individual factors, the patient level factors, the outcomes, different methods of follow-up, duration of follow-up, various methods of doing the analysis, etc. So various sources of heterogeneity are there, and we have this. What can you do about it? Because we are looking at published studies. You cannot reduce heterogeneity, but you can address those heterogeneity and find reasons for those heterogeneity. The classical test for heterogeneity in a meta-analysis is the Cochrane's Q, which is defined in this manner, which follows a chi-square distribution with k minus 1 degrees of freedom. Cochrane's Q is summation of wi into yi minus y bar whole square. Now, this Cochrane Q is a very good statistic, provided you have a large value of k. But systematic reviews are done on any number of studies. There is no golden rule for the number of studies to be included in a review. You can do a review with even 3 studies, even with 4 studies. But what happens is that when the number of studies is low, then the Cochrane's Q has a low power, and it is for larger number of studies only it has a larger power. So that is one that is one limitation of using a Cochrane's Q. So what the systematic review methodologists have done is that they have created another statistic which is called the I-square statistic, that helps us in quantifying the variation of the studies coming from individual studies, and that is defined in this manner. The I-square statistics is 100 into q minus degrees of freedom of q divided by q. Now this is a unitless study, a unitless metric, and it helps in providing you an idea about the heterogeneity between the studies. Larger the value of I-square, larger will be the heterogeneity between studies, and larger the need for doing a random effect model. If I-square statistics is low, then a fixed effect model can also be a very useful method of analysis for meta-analysis. So as we said, it's easily interpretable, easy to calculate, and it is an size and scale invariant. As a result, I-square is the most common metric that is used for reporting heterogeneity. When heterogeneity is found, then the reviewers cannot just say that there is heterogeneity, and you cannot publish that review without looking at or investigating the reasons for heterogeneity. For investigating the reasons for heterogeneity, various methods can be adopted. One is doing a meta-regression, which is a statistical method of looking at heterogeneity and identifying the sources of heterogeneity. And there are other graphical methods also which are useful for explaining heterogeneity, and these graphical methods are the subgroup analysis, the sensitivity analysis, and other graphical methods. So here is my favorite example here, where the study is on efficacy of BCG vaccination for tuberculosis. If you look at the forest plot in front of you, you see that there are multiple studies, and each study is you have all kinds of studies here. Studies, the square in each of these studies, it gives you the size of the study. Smaller the square, the smaller the size of the study. Larger the square, the larger the size of the study. So you have a very big square here, okay, which is a trial done in India, but you have multiple small studies. Some of them say that the risk ratio is lower than one, saying that BCG vaccination is protective for TB. There are others which do not have anything, because they are lying on the reference line, saying they are not very clear whether it is protective or not protective. So, but there are certain other studies which are small, with the smaller sample sizes, which clearly say that BCG vaccination is protective. However, when a systematic review, or sorry, a meta-analysis was done, we found that the I square was 92%, which clearly shows that these studies are highly heterogeneous, and whatever evidence you get from summarizing the findings of these studies are not going to be very useful, because they are all studies with varying levels of evidence, right? So one way is to combine the smaller studies and combine the larger studies. If larger studies are all tending towards a protective side, which you see here, that except for this study which is lying on the reference line, all other bigger studies are saying that it is protective, then you can come to a conclusion. But otherwise, if you combine all of these studies together, then the I square value stands at 92.92%, which is highly heterogeneous. This is another example where the study was to see whether saturated fat intake increases breast cancer. So what happened is that the reviewers tried to combine case control studies also and cohort studies also. So when they combined both the studies and generated the summary evidence, they found that it did not give any evidence. That means it was, there was no significant difference in the significance in the effect. But when they separated the cohort studies and the case control studies and did a subgroup analysis, they found clearly that cohort studies did not show any significance, whereas the case control studies, which are retrospective in nature, they clearly show that increased amount of saturated fat intake results in higher incidence of breast cancer. So this is one example where heterogeneity in the study designs could have led to wrong evidence if the subgroup analysis was not done. The other thing that also is done in meta-analysis is checking for publication bias. So studies are published in different languages. They are published in various journals which are not accessible. As I said, that some of the Indian journals are not cited in the PubMed, and therefore they will not be accessible to the Indian reviewers. So there could be multiple publications of the same thing. Multiple times authors would have published with slight differences. So all this is publication bias, and when publication bias occurs, then there has to be ways of detecting the publication bias. So there are statistical tests available for detecting publication bias, the Eggers test and all. And there is a graphical method, which is the most common method, which is called the funnel plot. So before I show the funnel plot, I also want to show you that there are various steps of it can occur, because they are primary or small studies which are more likely to be negative, and therefore they are unpublished. Publication bias happens because it is unpublished. It is also called file drawer problem, where the people don't publish their results. Then at the time of trial design and funding, the proposal is selectively, the funding agency looks only for positive studies and does not allow the researcher to do the study and then publish it. Then ethical board also sometimes does not approve certain trials. At the study completions phase, there is a possibility of publication bias because interim analysis has shown that the study is negative, and therefore we need not do the study completely. So there are various stages. Hello.
Yes, ma'am.
Hello. Am I
Yes, ma'am.
audible?
Yes, ma'am. You are audible.
Okay.
Yes, ma'am.
Okay. So there are various stages during a research process when there could be reasons for publication bias. So yeah. Okay. Is there anything wrong? Okay. So next is what kind of a plot do we use for publication bias? The funnel plot is the most common type of plot that is used for publication bias. How do you plot the funnel plot? You plot the odds ratios of individual studies on the x-axis and the standard error of those odds ratios on the y-axis, and then plot each dot is one individual study. So if there is no publication bias, then the plot should be looking like an inverted funnel. So if it looks like an inverted funnel, then that means all studies have been accounted for. There is no study which is unpublished. It is a comprehensive literature review, and you have included all the studies. But this is a very unrealistic graph that you see on the screen. It never happens. Most of the time you have a publication bias, and then your funnel plot doesn't look like an inverted funnel at all. So in such cases, there is a possibility that there could be heterogeneity, and you have to identify the source for heterogeneity. So once you do all that, the next step is to publish the results. You have done all the analysis, the statistical analysis that is also completed, and then following the PRISMA guidelines, you produce your results, show your results, and then the review is ready for publication. So when should you not do? When can a meta-analysis be misleading? A meta-analysis, as I said, cannot be done alone. It has to be done within a systematic review. When poor quality studies are included, then meta-analysis could be misleading because you have not appraised the individual studies properly, and therefore there could be a possibility that the results that you get from meta-analysis are misleading. There are some inconclusive studies that could also lead to a wrong result. And when inadequate attention is given to heterogeneity is there, but you have not looked for reasons for heterogeneity, then there could be a possibility of a wrong analysis, meta-analysis. Then there are many biases that could occur: publication bias, time lag bias, duplicate publication bias, all types of biases that could possibly give you a wrong or inappropriate result, and that could mislead the scientific community. What are the strengths of a meta-analysis? It definitely is better than just doing a systematic review, because if data is available, then definitely do a meta-analysis, because it imposes a discipline on the process of summing up the findings. It represents findings in a more differentiated and sophisticated manner than a conventional review. Then it is helpful for further looking for associations across studies, finding relationships between studies which otherwise would not have been possible. and the differences between studies can be quantified, and this method can handle as many studies as possible, unlike a systematic review where you have to just review the articles. Weaknesses are that you should be good in statistics, because it is more of a statistical problem, and therefore we advise that a systematic review is conducted, please include a statistician from the beginning itself and keep him updated on this. And there is a possibility that um, um, studies are included in the review because the reviewer thinks that this article is of importance, but actually there must be a quality issue in the article, and therefore it may not be the right primary study to be included.
So,
So there are a lot of meta-analysis software. Some of them are commercial and some of them are free. You can use any of them. Revman, earlier it was free. I think now it is priced. Then there are many other softwares available for doing meta-analysis. Even Stata can be used for meta-analysis. These are some of the books that you can use for meta-analysis. These are some guides for conducting systematic review. These are very useful guides for conducting systematic reviews. These are some of useful pages. And that's all. So that's all from my side. Dr. Verma. Hello, I am audible or
Ma'am,
not?
yes, ma'am. Yes, ma'am, you're audible. Thank you so much. So please, over to you, sir.
Any questions? Thank you.
Thank you, ma'am.
How many of them are clinicians in this group? So they all know the other subject. Good, good. So yeah, hands-on is going to help. That will be more interesting. Rambat, yeah, I know. Yeah, so yeah. So you, and at least there is the clinicians, they should know some background statistics before they apply it, because otherwise, yeah, the clinical problem they understand, but the statistical portion is the one that they need to know. Yeah, say patient, yes. No, it's the problem is that for a systematic review, you need a clinician, because only a clinician can pose a clinical problem, right? A statistician cannot pose a clinical problem, but the statistician has to be there throughout, because then only you can give the right kind of results that he is looking for, summarize the results, the statistical concepts and all should be clear. Protocol is a must. Yes, yes. So yes. So, but you know what? The systematic review started in social sciences. Yes, systematic review started in social sciences. It came to health sciences later on. So they definitely do it. Only thing is that they do it on correlation. They do it on other effect measures, whereas we do it on odds ratios, risk ratios, and all. Sensitivity, specificity. Yeah, ours is clinically defined measures. Theirs is more social measures. Who said that? Dr. Kameshwar Prasad is an authority. I am a student of Dr. Kameshwar Prasad. So I am his, he is my guide. He is very good. He is very good. So Amit is also there, na? Amit. He is very good. Any uh, You were in Delhi? Acha. Okay. Stroke study? Yeah, what was it called? I aim. Acha, okay. I don't know. I don't know. You were there in that. But Dr. Kameshwar Prasad knows statistics very well. No, he is very good. He is very good. I learned all this from him only. Yeah, yeah. Jitender is here. Jitender,
Yes,
you are going
ma'am.
for a walk?
Yes, ma'am. Yes, ma'am.
Statistical walk.
Yes, ma'am. By walking, I am listening your lecture.
चलो ये अच्छा है वेरी गुड thank you for giving me an opportunity to talk. I don't think anybody has any questions. Okay. अच्छा हाँ हाँ no problem, no problem. Systematic review, speaking on systematic review is not a problem at all. I enjoy giving lectures. I have repeated it so many times, no? Yes. Chalo, if there is no, I don't think anybody has any questions. Okay, thank you so much. Thank you. Thank
Thank you,
you.
madam.
Okay. Thank you. Bye bye.
Thank you, sir. Thank you, sir.